Dr. Roger Albin from Udall Center at University of Michigan, Dr. Eleanor Orehek, the Medical Director of the APDA Minnesota chapter, and Karlin Schroeder, Director of Community Engagement at the Parkinson's Foundation. Our speakers have a great set of presentations to share with us today. We would also like to thank our event sponsors today, AbbVie, Amneal Pharmaceuticals, Acadia Pharmaceuticals, Adamas, Accorda Therapeutics, Medtronic, and Supernus Pharmaceuticals. We'd also like to thank today's silver level sponsors, Boston Scientific and Kiowa Kirin.
Today's session will be recorded and archived on the APDA, Parkinson's Foundation, and Udall Center websites. We have slides available in the chat function in the black banner at the bottom of your viewing page for you to follow along with today's presentations. We would like to know a little bit about our audience today. You will see a poll pop up on your screen asking, what is your connection to Parkinson's disease? We'll give a few moments for everyone to click on their response. Wonderful, thank you for responding. And with that, I would like to introduce Dr. Eleanor Orehek, our first presenter. Dr. Orehek is a movement disorder specialist at the Noran Neurological Clinic and the medical director of the APDA Minnesota chapter. Dr. Orehek will be sharing an overview of the stages of Parkinson's disease.
Good morning, everybody. We're so happy that you all could join us today, and I think we'll cover some good information during today's session. Everything's a little different these days with the pandemic and trying to get accustomed to using technology in different ways, and so it's a change from having a room that I'm used to, but I think it's still a good way to deliver this important information. So I am going to talk about the stages of Parkinson's and try to address the challenging topic of assessing a complex disease and how to kind of move forward with hopefully some additional information that you'll gain, and also just some advice on managing the ambiguity and an uncomfortable or unpredictable nature of this disease. So we live in a world where you can pull out a device and it tells you exactly where you are pretty much everywhere in the world, and it can tell you where you need to go. And so, you know, why can't we have something like that for Parkinson's, where you can gauge where you are and where you're headed, because a lot of people want to try to understand where they are in the disease so you can get a better sense of what the future holds. And we unfortunately don't for Parkinson's, but trying to get some measures and tools and ways of assessing the disease would be the goal for now and also in the future. So the tools we have some scales and idea of how someone's doing with the disease and aspects of the disease, but there's limitations to those. And then there is a BRAAK staging method that I will review as well, that's based more on the pathology in the brain and kind of how we view some of the progression of the disease. So the Hoehn and Yahr scale, this was developed by Melvin Yahr and Margaret Hoehn, who are pictured here, and was published in 1967. So It's been around, obviously, a number of years. It is the most widely used scale, just mainly because of its simplicity. So there's 5 stages, and there's good and bad aspects to it. It's a little bit messy because it combines kind of what we view as more functional disability, but also more objective physical signs on exam. And so trying to combine those two and gauge where someone's at makes it a little bit challenging. Going through the stages here. So if you've heard about, you know, stages of Parkinson's and what stage I'm in, this scale is often what people will be referring to. So if it does mainly take into account motor symptoms, so that's one of its drawbacks, is that it kind of non-motor symptoms that are often have as big or bigger impact on someone's quality of life and function. So stage more one-sided involvement, right-sided. So this also is where it might not take into account some of even the motor impact of someone's symptoms. So if you're stage 1, but your symptoms on that one side are severe tremor or severe rigidity or dystonia, you might be on this scale in a very early or mild stage, but you have more disability from that motor symptom versus someone who stage 3 on the scale but not be as impacted by their symptoms because they have more bilateral movement but mild symptoms on both sides. So one thing to take into account when you're looking at these scales. So then you move through, and stage 2 is having symptoms on both sides, but you're still walking well and not having any impairment in balance. Moving into stage 3, you do have some more instability with your posture and might start needing or just being more cautious when you're walking.
Dr. Orehek, can I cut in for just one moment?
Yes.
And could you please switch to slideshow mode? We currently have you in presenter mode.
Okay.
And if you could move a little bit closer to your screen so we can hear you better, that would be very much appreciated. Thank you.
And slideshow mode would be, so you can't see my slides, or? All right.
We can see your slides. We're just seeing presenter mode. So we're also seeing the next slide as well as your current slide.
Oh, I see. Okay.
There we go. Thank you so much.
Sorry about that. All right, so going back to the Hoehn and Yahr scale, we have the mild to moderate stage 3, where you're maybe needing a little bit more assistance or caution when you're walking, and then stage 4, you're going to need a walker or other assistive device to ambulate safely, and then stage 5 would be more kind of dependent on 24/7 care. And again, this could be years into the disease, so this is variable, and some people might not ever reach stage 5, depending on what else happens in your life and other health factors. So this is the BRAAK staging of Parkinson's. And he was a pathologist that published this research in 2003, looking more at actual brains of people with Parkinson's and evaluating where the changes in the brain were occurring at different stages of the disease. So he found that in early stage, if people had either minimal motor symptoms or no motor symptoms, the changes in the brain tended to be lower down in the brainstem and affecting more areas that are involved in autonomic function, which would be constipation type of symptoms affecting the GI tract, and also loss of sense of smell. So that's why early changes in sense of smell can be what we might consider pre-motor symptoms of the disease. And then when you get into stage 3 and 4 on his staging system, you're looking at where most people with Parkinson's would be actually diagnosed the way we look at it now, because that's when you start developing the motor symptoms of Parkinson's. And that's because the changes in the brain have spread into those areas involved in motor function. And often at that stage, that's when some of the sleep can occur, and REM, sleep behavior disorder, if you have that, you're aware of that, where you act out your dreams in your sleep. So that's one of the non-motor symptoms that we can see, and that one can occur even before diagnosis, and can be a premotor symptom as well. And then later on in the disease, the changes in the brain can spread to areas that affect thinking and memory more, or mood changes. And so he found that in people with later stage of Parkinson's clinically had more spread of changes in the brain that was seen. So one rating scale that can be used as a tool to gauge where someone's at with their disease is called the Unified Parkinson's Disease Rating Scale, or the UPDRS. So this is more time intensive than the Hoehn and Yahr scale, but takes into account more aspects of the disease. So there's non-motor evaluation and a questionnaire that people with Parkinson's would fill out, or a caregiver would fill out, that assesses where someone's at with their thinking and memory, their mood, any behavior changes. How are you functioning with activities of daily living, like eating, dressing, speaking, handwriting. And then there's a motor section, which I do components of this often in your clinic visits, where we're tapping the fingers and doing this and looking at your muscle tone, and that there's a whole scale you can do and come up with a number. And then complications of therapy would be looking at, do you get side effects from the medication? Are you getting bothersome dyskinesias, which are those wiggly movements that happen from the levodopa? And then there's a section that looks at your Hoehn and Yahr stage as well, and then gets incorporated into the total number. So 0 would be no symptoms or disability from the disease, and then the highest score would be 199. So quite an elaborate questionnaire, but is used often in research settings, or if we're looking at deep brain stimulation candidates, we'll use the motor section of the UPDRS to look at how someone's doing. This changes quite a bit depending on how much medication you have on board. So that's one reason that it's not quite reliable when you're looking at someone in the clinic who's on medication or off medication, or at different stages of where that medication cycle is. So you might get a lower number one visit and higher number the next visit, more because of medication and less because of the disease progression. So sometimes harder to gauge unless you're doing it in a controlled, more research type of setting. So as you probably know or are learning, that Parkinson's is a really complex aspects that are important to take into account. So the motor symptoms, the non-motor symptoms, we have the rating scales that we talked about. Another thing that people are looking at are biomarkers of the disease, are markers that we can look at that give us a better way to diagnose it, but also track the disease progression. So biomarkers are pretty varied as far as their availability. So that's a measurable marker of a biologic process or disease is the definition. Anything from an exam finding to blood pressure, imaging, if you're collecting blood or spinal fluid, that can be ways of collecting biomarkers. So in Parkinson's right now, the biomarkers that we would have available would be like the UPDRS or the DAT scan. So you might not all be familiar with that, but that's a scan that we can do that looks at dopamine transmission in the brain and is used more as a secondary validation tool for a diagnosis of Parkinson's. It's not used to track progression, and it's not used to differentiate Parkinson's disease from some of the atypical diseases that also can act like Parkinson's but might progress differently. There's a lot of research in this area looking at diagnosing and tracking the disease. So finding something that is fairly easy to measure. So it would be nice if you didn't have to have a spinal to check where the disease was at. So finding something in the blood or a different modality that would be a little bit easier to obtain would be the goal. And then you would also want it to be reliable and valid so that you could effectively track how the disease is progressing. So other things that also affect how someone might be doing or managing their disease that some of these scales don't take into account would be age, other medical problems, how much social support does someone have, other obligations. Are you a parent of young children? Do you have older parents that you're trying to care for? Do you have financial stressors? So all of these things impact how someone might be functioning or managing the disease that's hard to quantify. This that just kind of more clearly outlines the motor and non-motor symptoms that we look at, and again are important to take into account when you're trying to assess how someone's managing the disease and what factors we need to help someone as much as we can. So having a lot of tremor would be disabling for somebody, but there are people without much tremor that's bothersome, and they might have more issues with sleep or apathy or fatigue that can be quite disabling. So looking at all these things and taking them into account is important. So just going into the motor symptoms in a little bit more detail again, if you simplify it a little bit more, even from the Hoehn and Yahr stage, you can look at earlier mild stage symptoms. You're going to have mild functional impairment, significant impairment, so you would still be able to work and do most activities that you would enjoy doing. In the moderate stage, you might have more disabling symptoms, so you might be transitioning from working. If you're still working age, you might be looking at disability. Medications might be having more side effects, and then in more advanced stage, you might have more disability from there, needing more help and care. And here's just another graph of looking at some of the changes that happen as the disease progresses in response to the medication. So in early stage, the medications tend to manage the disease symptoms quite well from a motor symptom standpoint. And then in moderate stage, you might have more motor fluctuations, we call them. So that's where the peak of the dose of the carbidopa-levodopa might start causing more dyskinesia. And as it wears off, you kind of leave that therapeutic window and have more of your Parkinson's symptoms return. And as the disease goes on, this can get more dramatic, where it's harder to stay in this on time or therapeutic window without having either bothersome dyskinesias or wearing off. So that's when looking at other treatment options like deep brain stimulation or different delivery methods of carbidopa levodopa in that moderate to severe stage would be indicated. So non-motor symptoms to think about, again, there's a range of symptoms, and so some of these are occurring throughout the whole process. Some of them might happen in the beginning and not be as much of an issue later, or vice versa. So constipation is definitely one of those early, even pre-motor symptoms that we see, so pre-diagnosis. Depression's often co-occurring with the time of diagnosis. Sleep issues are common early and later in the disease. Apathy, so that's lack of motivation. So that's challenging because it gets in the way of doing what you know you're supposed to do, like exercise and eating well and things that help you, but are really challenging for you to actually take action on. And then later in the disease, so cognitive changes, sleep issues, again, hallucinations can be a part of the disease, so that's something to just monitor and watch out for. Blood pressure issues and can occur early and late, again, but can be more of an issue later in the disease. On standing and mood changes again. So taking all of this and having this disease that's complex and you know it's tough to manage, it's going to be a long road, there's ups and downs, and so how do you kind of cope with that, and where do we go from here? I like this quote from Michael J. Fox that don't imagine the worst. If you imagine the worst and it happens, you've lived it twice. So trying not to get too entrenched in worrying about the future because we don't really know what's going to happen, and there's only so many things you can control for. So things in the early stage, if you've just been diagnosed or you're in earlier stages, again, exercise is one of my main things that I push frequently. So that's always on the plan or part of the management strategy. The apathy that I talked about, so making sure you come up with a routine and strategies of getting in exercise, a social interaction, something mentally stimulating, trying to do those things every day, even if you're not feeling up to it, can really make a difference. And then, so going back to how do you plan for the future and how do you going to happen? Well, you can't, and you again don't want to worry too much about it, but you can plan for the worst and hope for the best, the old proverb or saying. So have a backup plan, have an advance directive. You can work with an attorney or someone that's specialized in kind of elder care and make sure everything's set up as best you can, and then just kind of put it aside and have it there for the future if you need it. Other things that are important at any stage in the disease is to come up with a very comprehensive support system. So you want to make sure you have a care partner or someone that's going to be there if you need help with things. Having therapies, even early stage physical therapy, occupational therapy, speech therapy can be very helpful. Given the anxiety, depression, mood issues, difficulty coping with the chronic disease, having mental health support, having a psychologist that helps with some of that coping strategies and difficulty, and someone to check in with regularly that's an independent party and not your caregiver or care partner, and not always having to fall back on friends and family, and having that outside support and beneficial. Your neurologist is an important part of your care team. A good primary care doctor is important. One question I get a lot is, well, how do I decide what I'm experiencing is part of Parkinson's, or is it my age? Is it something else? And so having good providers that you can go to say, this is what I'm feeling or noticing, and having them help you work through that can be really important. And then the organizations like the APDA that has a Minnesota chapter, Parkinson's Foundation has a Minnesota chapter. They can be great resources to go to get information about the disease and support and planning for the future, and just getting all of that lined up and set up can be very helpful. So again, later stage management exercise, it's on here again because I just think it's invaluable to have a regular exercise program. Continue to build your support network. The support in later stage gets even more important. So make sure you have that you evaluate your living situation, make sure things are safe around the home. Those things are important to consider. So my advice and takeaways at this point would be, a lot of people say, well, be positive, live in the moment, and you have Parkinson's, so you're gonna feel crappy, for the lack of a better word, sometimes, and that's okay too, because you have fluctuations and your meds don't always work right, and so if you're having an off time or a bad day, that's going to happen, and that's okay. So it is good to stay in the present and not think too much about the past or worry about the future, but give yourself freedom to feel what you're feeling, and don't feel guilty if you didn't do what you were supposed to that day, because it's a long road and it's a tough disease, and as long as you do the most of what you can, so grieve. There's things that you're gonna not be able to do that you wish you could do, and you can grieve that, but try to focus on things you can still do, things you might be able to do that you didn't do before, learn a new hobby, meet different friends and people that you might not have otherwise met if you didn't have Parkinson's. So focusing on those things, I think, can really make a difference. And be flexible, so you have ability to adapt to different situations. So finally, another Michael J. Fox quote. He has a lot of inspiring ideas and thoughts about the disease. So he says, I don't have any choice whether or not I have Parkinson's, but surrounding that non-choice is a million other choices that I can make. So even being here on this webinar today is a positive choice that you've made to help manage your disease. So just have hope for the future and keep working. And we can take questions. Yes.
Dr. Orehek, thank you so much. I especially love those powerful quotes that you shared from Michael J. Fox. And we have had questions come in from our attendees, so I'll get started and share some of the questions that people have for you. So one person asked, how often should you see the neurologist? Once a year or only when your symptoms change?
So that's a good question. I usually like to see my patients at least twice a year, if not 3 times a year. So I'll depending on how someone's doing, if someone's really stable, I push it to a year sometimes, but every 6 months seems to work the best, just given the number of things that come up at visits and things that we need to address. So, and then sometimes it's more frequent than that if we've made a lot of medication changes. And now with, if you're comfortable using virtual appointments and telemedicine, doing a check-in or an appointment is easier, because you don't have to worry about leaving your home or getting into the clinic and how you're going to get there. So even more frequent every month or couple months if we've made a lot of changes can help.
Fantastic. And someone else asked, what do you do if a family member of the person with Parkinson's asks you to consider telling the patient to make some changes in their driving or not to drive? How do you evaluate the person with Parkinson's on their driving safety?
So this is a great question and a tough question, because driving is one of those things that is a big sign of independence. And if someone is getting to a point where you don't feel that it's safe for them to drive, I think the best way, if you're uncomfortable bringing it up to your loved one or person that has Parkinson's, you can bring it up in an office visit and address it that way. And a lot of times if that concern is raised and there's some discrepancy between the person and the loved one of whether it's safe to drive, I'll refer them for a driving assessment. So Courage Kenny has occupational therapists that will do a road test and assess safety and look at a number of different things, and that doesn't go through the DMV. So it can be done independently, and then still is a decision between family and doctor and the person on what's safe. So I find that to be a very helpful tool.
Great. And someone else asked, do you have any recommendations for safe exercise or suggestions about types of safe exercise specifically for people in later stages of Parkinson's?
So safe exercise in later stage, so that would be if there's concerns about postural instability or fall risk, if you're going to be doing things up on your feet, so then you probably want to do more seated types of exercise. So I often refer to Sit and Be Fit is a company that does seated exercises that are available online in video. I think you can get actual DVDs or videos too. So those are good, and especially now in the pandemic with gyms, being closed or unsafe, that there's more online content. So if you're able to access videos online, there will be different exercises that you can look at and see which types of more seated types of exercises would be good. Another thing I've had, especially if you don't have room in your place for a full stationary exercise bike, they have the floor pedalers or something you just put on the floor and someone can sit in the chair and exercise that way. So those are ideas.
And great, thank you. And we have another question. What are you currently recommending for patients who are having breakthrough symptoms?
So breakthrough symptoms would be the equivalent of having off time. So that's when your Parkinson's symptoms are returning. And it's a tough question because there's a variety of different medications we could try and changes in the timing of how you take your medications or adding a different medication. So I really would have to talk to the individual about that one.
Okay, great. And someone else has asked, how do you handle freezing episodes? They're happening much more frequently and causing me a lot of anxiety.
So freezing episodes can be also really challenging and often don't necessarily respond to the medication. If it does feel like they're better when your levodopa or your Sinemet is on board or your medications are working, then we can try to help adjust them. If you're still freezing even when your medications are working, then there's a variety of different strategies that you can find on gate freezing information online, or there's handouts that either the Parkinson's Foundation or the APDA would have about tips for freezing. So you can look into those strategies, because there's things like taking a deep breath and then counting your steps, or marching instead of walking. So a variety of things. And then being aware of which situations tend to cause you to freeze can help you also troubleshoot.
Great. Someone else has asked, when should we start finding our care team or support system and getting things lined up?
I think for that, earlier the better. I mean, you can't start too early. Getting good people in place to help manage things, even if you don't necessarily need them a lot right now. If having a good place to go for therapies in the future, or seeing a physical therapist, even if they say, yeah, things look good, I don't think we need to do much, that's okay. At least you've established that relationship. And same thing with mental health, or just thinking about future care needs, what that looks like, and different organizations that can help provide that care can be helpful to at least be aware of what's out there.
Great. And someone else has asked, do some people progress through Parkinson's faster, or are they diagnosed later? Or is it a different disease, referring to things like Lewy body specifically?
Yeah, so this is also a great question. And because you hear about people say, you know, oh, I have a friend with Parkinson's and they progress so quickly over a number, or just over a few years. And then that always is a question, well, did they actually have Parkinson's disease, or was it Lewy body disease, like dementia with Lewy bodies, or was it PSP, which is progressive supranuclear palsy, or multiple system atrophy. So some of these other diseases that at first might look like Parkinson's, but can progress more quickly or differently. And that's where it goes back to having better diagnostic tools and better biomarkers would help us differentiate between these different types of diseases, so that we have a better idea of how someone will progress.
Thank you. And someone else has asked, since apathy is a common non-motor symptom, what do you recommend for people who are struggling with apathy?
Yeah, apathy is tough, and it would be nice. I mean, not that people want more pills or medication, but you know, we don't even have a medication that we could try to help with apathy, unless it's also some depression, and then we can try to treat that. So you can try on your own or with a care person or a loved one, to come up with those routines and day-to-day, like set your goals, set your priorities. What do you want to accomplish in a day? And then really hold yourself to that, or have someone that can help you hold yourself to that. If you're even struggling with that and kind of in more of a negative thought process, having a psychologist or counselor work with you on cognitive behavioral therapy or strategies, just with a more regular check-in on how things are going and how your plan's going, can make a big difference too.
I think that's fantastic advice. Thank you. And now I want to move into our last question. Someone has asked, does the appearance of certain non-motor symptoms signal a progression to another stage of Parkinson's? And again, this is our last question.
Yeah, and most non-motor symptoms, I would say, can occur at any stage, so that it doesn't help that much as far as staging. The main one that I would say usually indicates you're moving into a later stage would be cognitive changes to the point of dementia. So if you're having more and cognitive changes that's impacting your ability to take care of some activities of daily living, then that would indicate you're moving into those later stages.
Thank you so much. And that is the end of our Q&A session with Dr. Orehek. Dr. Orehek, we really appreciate you sharing your time and presentation with us today. And we will now take a short break. We encourage you all to follow along with this exercise video shared by the APDA.
Hi everybody, this is Angela with the APDA, and today I'm bringing you 3 quick and easy exercises to improve strength in your legs and your glutes. Really important muscles for doing activities that we do every day, all day long. These are 3 easy exercises. You can do 10 sets of 10 at a time. You can do 2 or 3 sets all at the same time, or you can do 1 set in the morning, 1 set in the afternoon, 1 set in the evening, however you want to do it. It's your decision. 3 easy exercises that you can do right in your own kitchen. All you need, nice sturdy countertop to hold on to. You can do it in your bathroom. You could do it with a nice sturdy chair as well if you don't have a countertop to hold on to. But really quick and easy exercises. Let's get started. The first one that we're going to do, just your basic squat. Now, a couple important facts here that we have to make sure that we do. I want your feet to be underneath your shoulders at least. You can go a little wider if you want, but don't go more narrow. I need your feet to at least be hip distance apart. So straight down from your shoulders, hips, all the way down to your feet. We're gonna hold on to the countertop. If you're feeling stable and secure, you can hold on with one hand. You can take that other arm out to the side or on your hip. We're just gonna push our butt straight back and stand up. Like you're sitting down in a chair and stand up. Sit down, stand up. If you feel like you need a little bit more support, you can also do it holding onto the countertop with both hands. Same thing, make sure those feet are nice and wide, and we're just gonna sit back down in it and stand up. Sit down and stand up. You can do about 10 or so in a row. Repeat if you want, or do it another set later on. Exercise number 2 is gonna be a leg lift to the side. Once again, we're gonna keep those feet about shoulder width apart to start, nice stable base. Either one hand on that countertop or both hands on the countertop facing the counter. Either way, I'm going to show it to you this way so you can see what I'm doing. Nice stable base, holding on to the counter. One arm can be out to the side or on your hip, you decide. And we're just going to lift and lower that leg. Make sure we're standing up nice and tall. That chest is lifted, our head is up, our shoulders are up, back, and down. We have nice posture while we're working on this one as well. And we're just lifting and lowering that leg. If you need a substitution, if you can't quite get your leg all the way up, no problem. We can just stand up nice and tall, our feet are wide, and we're just gonna tap to the side and back in. Just tap and in, standing up nice and tall. All right, make sure you do both legs. So you would just switch sides or face this way, do both legs, do about 10 repetitions on each leg. You can repeat that if you want at the same time or repeat it later on, you decide. For the third exercise, we are going to do lunges. Now, once again, holding on to that countertop. You can be facing straight on, and with one hand on the countertop, we're just gonna lunge forward and come back. Lunge forward and come back. If you wanna add on to this exercise, you could have some hand weights as well. Hold one weight in your hand that's not holding onto the countertop. And just do a basic curl when you're doing that lunge. All right? You can also lunge backwards as well. Take a step back, bring it back in. Take a step back, bring it back in. Make sure we keep our chest and our head up the whole time during this exercise. If you need more support and you need to hold on to the countertop, both hands on the countertop, same thing. We're just gonna step back and bring it in. Step back and bring it in, nice and easy. Remember, you don't have to take that big of a step. You can modify. If you just want to take a small step, just a small step, bend both knees, bring it back up. Same thing going backwards. Small step, little bit down and up, and bring it back in. Really easy. That's what's so great about these 3 exercises. You can modify them to fit your needs. I hope you guys have a wonderful day. Do these 3 exercises and you'll feel great.
Okay, before we jump into our next speaker, I want to take a quick poll here. And we are just going to ask about how many people are watching this webinar with you. So I will send that out. Thank you guys for participating in these polls. It gives us a lot of great information. So without further ado, we are going to move into Dr. Roger Albin's talk now. Dr. Albin is the director of the Udall Center at the University of Michigan. He is going to be presenting some of his research on non-motor symptoms of Parkinson's disease. And without further ado, I will turn it over to you, Dr. Albin.
Okay. Thank you. Everybody hear me okay? And I think we have the video, we have the presentation up. So I'm going to talk today primarily about some research our group's been doing on actually something that is actually sort of in the middle of between a motor and a non-motor feature of Parkinson's disease. And this is, I want to stress, this is really a group effort on the part of a number of us here in the Udall Center at Michigan. And in particular, what I want to talk about actually is a fairly troublesome aspect of Parkinson's disease, which is related to falls. And
can I just quickly interrupt? I think we're going to have you share your slides.
Okay. Oh, you haven't got the screen sharing up. Yeah, just a second. Sorry.
No, don't be sorry. Thank you.
Yeah. Okay. Here we go. Let's take a look. Okay. Okay, are we all set now?
Yep, looks great. Thank you.
Okay. So first of all, these are just some of my disclosures, none of which are relevant to this talk. Particularly, I want to say I'm very grateful to the Parkinson's Foundation for the support that we've received for our research efforts. And I'm going to talk a little bit about why we're interested in this particular problem, and then a little bit about the research tool that we use to study it, and then how that kind of information leads to development of an animal model, and then conclude by talking about a human experiment, which is an effort to try and actually extend some of this research into something that might ultimately be useful for patients. Now, as I think probably a number of you have already experienced, falls, walking, and balance problems are major difficulties, particularly in more advanced Parkinson's disease. And Dr. Orehek mentioned in her very nice talk the Hoehn and Yahr scale. And in this first figure, what you can see is this is looking at progression of Parkinson's disease through the various Hoehn and Yahr stages. And when you get to Hoehn and Yahr stage 3, this is the stage at which people start to have difficulties with balance. And what you can see on this graph is that this is with a measure of a questionnaire measure of quality of life. And the higher the number, the worse the quality of life. What happens is when you start to get to that point at which people have difficulties with their balance, that's a point at which there's really a major decline in the quality of life of Parkinson's patients. And in addition, this is very common. So on the right side of the screen, this is data from a very well done British study. And what this shows is that after 5 years of Parkinson's disease, about half of patients will have this kind of balance problem. So certainly not all of them, but a very high percentage do. And one popular number is that about 70% of Parkinson's patients have a fall in any given year, and many patients with Parkinson's disease have frequent repeated falls. And falls in Parkinson's patients, falls in elderly people in general can be a serious problem, but more so in Parkinson's patients. So they're more likely to lead to a serious fracture, to hospitalization, and to nursing home placement. Now, the key point, though, is that I think walking is really a very cognitively demanding task. So, walking really is thinking. A way that walking's been described, at least for humans, and one of the small group of animals that actually walk primarily on 2 feet, is that you're actually throwing yourself forward to fall, then rescuing yourself at the last minute. And we've all had that experience. If you're not paying attention when you're walking, you'll trip or slip. So walking actually demands a lot in terms of maintaining your attention and focus on your environment, usually done in a very unconscious manner. But in Parkinson's disease, as the mechanisms underlying walking start to break down, and as that some of the systems of your brain that are responsible for paying attention start to break down, then you're more likely to have falls. And then even a minor disturbance or a minor slip can turn into something more serious. And on the right side of the screen, this is some data not from Parkinson's patients, but actually from older individuals in Australia. And what you're looking at in the top part of the figure is EF stands for executive function. So this is a measure of your ability to switch from one task to another or to pay attention. And so what you see is individuals who have good executive function have a much lower rate of falls than individuals who have problems with that. And the lower figure, what DT stands for, is dual task. And this is a very simple examination maneuver in which an individual is asked to walk down a hallway, and they're asked to see how fast or what their walk is like just an ordinary walk, but then they're asked to do something that imposes some additional burden on their ability to pay attention, a distraction. So a distraction is usually counting backwards from 100 or something like that. And individuals who have changes in their gait under those circumstances actually have a much higher fall risk. So that suggests that, in fact, if your ability to pay attention or to monitor your surroundings appropriately, then you'll have difficulties with walking. And this video, which is a fairly well-known video done by a group in Holland, shows difficulties with freezing, which is this gentleman starts to freeze. And in particular, he's freezing as he gets onto this piece of cloth on the ground, which is that somehow the change in the visual environment has triggered a freezing episode. And you can see the same problem occurs with turning. So something that requires sort of a change in the way your brain is supposed to work or the way your motor system is supposed to work, or some change in your environment precipitates a freezing episode. And here, this is the same individual who is trying to go through a doorway. And again, the typical difficulty in starting movement, but also there's some difficulty because he's approaching the doorway and getting stuck. And as you can see, he has a little bit of hesitation right when he's on the threshold of the doorway. Okay. So how would you study something like this, and what's going on in the brain of individuals with these kind of problems? So the primary tool that we use at our center is something called positron emission tomography. And this is a very sophisticated combination of actually nuclear physics, chemistry, and advanced imaging methods. And what it allows you to do is to study very specific changes in brain function in living individuals. And essentially what you're doing is making target molecules or signal molecules that will bind to some target in the brain with very, very high specificity. And then we can use nuclear medicine techniques, radioisotopes, to actually measure how much of those molecules are bound to specific parts or specific functions in the brain, and actually quantify that. And this allows us to actually study basic biochemical and brain signaling processes in living patients. And just as an example, everyone in this audience here is familiar with the concept that a major feature of Parkinson's disease is loss of dopamine. And that loss of dopamine is due to the degeneration of neurons in the midbrain, the substantia nigra, and that results in a loss of dopamine being sent to a farther forward part of the brain called the striatum. And this has been known for decades based on pathology studies. But if you use the right PET method, you can actually demonstrate this in living patients. So what you can see here, this is a PET method which actually measures the integrity of dopamine neurons in the brain of living people. And this is a normal 30-year-old, this is a healthy 70-year-old, and this is a Parkinson's disease subject. And you can see there's obviously a dramatic difference. What you can also see is that there's a little difference between the 30-year-old and the 70-year-old. And the great thing about this particular method is that not only can you make pretty pictures, but you can actually measure changes in the brain with considerable precision. So for example, this is a study that we did looking at a large number of both normal patients, the circles, and Parkinson's disease individuals, down here in the squares on the bottom. And what you can see, the Parkinson's disease individuals are markedly different than the normal individuals. But the normal individuals display a gradual age-related decline in their dopamine neurons, starting from about age 20 to age up until the 80s. And this is something that was previously seen in studies done at postmortem, but we can actually show this in living individuals and measure it with considerable precision. Now, we can do more than measure just dopamine. What our group is really focused on is on another important brain chemical messenger called acetylcholine. And this is a little bit like the dopamine system in that all the acetylcholine in your brain comes from a couple small groups of nerve cells right down at the base of the brain, and then they project diffusely throughout the brain. And whereas dopamine has been strongly tied to movement, what acetylcholine and its system is tied to is actually various aspects of thinking and memory, particularly the ability to focus and pay attention appropriately. And our group developed a method to actually look at this particular brain system, again, using PET imaging in individuals, in living individuals. And this is what the acetylcholine system looks like in the brains of normal individuals. Now, these are consecutive slices through the brain, through the head, as it were. And you're going from top to bottom. And you can see these are different regions. That the dark indicates regions where there's a lot of this particular messenger chemical. And in particular, these very dark comma-shaped regions, these are the striatum. And this is the region that's also where dopamine goes and from which dopamine gets lost in Parkinson's disease. So right off the bat, we know that there's some potential there for some interactions between the two of them. We also know that this particular chemical is very important in the cortex, the outside of the brain, the parts of the brain that are thought to be very important in terms of various cognitive functions. So memory functions, attention functions, executive functions, a whole bunch of different aspects of thinking and memory. And you can quantitate this quite precisely. So this is a comparison of some younger individuals and some older, just normal, healthy, older individuals, looking at the distribution and quantitation of this particular brain messenger. And what you can see here in the younger individuals, you can see just various cortical regions. It's quite robust. But as people get older, they actually lose some of this chemical. And this may correlate with some normal age-related changes in thinking and memory. However, in many Parkinson's patients, we see a much more dramatic difference. So this is, on the left here, you can see this is dopamine system studied with PET, and you can see here's a normal individual, here's a Parkinson's disease patient, obviously quite different. And this is doing the same type of comparison with acetylcholine. And here looking in the surface of the brain, so the more cognitively important parts of the brain, you can see here, there's a normal control individual, and here's an individual with Parkinson's disease. And one of the major differences between these two is that this does definitely correlate with some impairments in cognitive function. Now, it's also important, we also want to mention that this is not true. Not every patient with Parkinson's disease has this change. So, for example, this is a comparison study of within Parkinson's patients, looking at Parkinson's patients who have this kind of abnormality and those who don't. And probably about half of the patients that we study have this particular abnormality. In yellow here, this is a loss of these types of this chemical messenger. But one half the Parkinson's patients studied don't have it. In particular, what seems to be the case with the patients who have this deficiency is that they're much more likely to have problems with falls, with freezing, and with balance in general. So we think that this particular loss of this particular brain system or impairment of this particular brain system is particularly important for the control of things like gait and posture, but not in an obvious way. Again, this is a system which is thought to be involved in aspects of cognition, particularly attention. And the idea then is that because you can't pay attention properly, superimposed on the problems you have related to your dopamine loss, then you're more likely to have falls. Now, with that in mind, the next step is actually to see whether or not you can actually mimic this in animals. And this has a couple of difficulties. The most commonly used animals for research are mice and rats. And mice and rats walk on 4 feet, so they're quite different. And balance functions are somewhat different in a mouse or rat than they are in humans. So it becomes a little challenging to try and figure out how to do these, how to develop a model. So one of our colleagues at Michigan, Professor Martin Sarter, developed a very elaborate system to precisely measure gait and balance problems in mice and rats. And this is his device. This is basically, you start with walking across a beam. This would just be like, just walking across a straight beam. But then you can make this more complicated. You can tilt it, so make it more challenging. You can make the beam different shapes. You can make the beam move so that it's more challenging to walk across. And his latest version, he has the zigzag beam, and this beam actually rotates, and it's a very challenging task to walk across. And even a rodent walking on 4 legs will have some difficulty with this particular task. And now in addition to that, you can impose additional conditions. So for example, what you're seeing here, this is actually a doorway that's put over the beam and is a distraction. And down here, this is another distraction where a food item is offered to the rat as it's trying to walk across the beam. And what he's done then is to mimic what we see in the Parkinson's patients. So this is the normal brain here, and this is the dopamine circuitry here, and this is the acetylcholine circuitry going up to the higher parts of the brain, the cortex. And then you can experimentally destroy both of these projections and see what happens. And this voiceover should be from my colleague, Bill Dower, who's at the University of Michigan, talking about some of our initial results with this. So what you can see.
Control animals are easily able to traverse a rotating beam and pass through a doorway distractor without difficulty.
Now this is the animal with mimicking the Parkinson's disease patient.
Dual lesioned animals are also able to traverse the rotating beam, but become stuck at a doorway distractor and fall. Even in the absence of a rotating beam, dual lesioned animals become stuck with freezing type behavior at the doorway distractor. This type of behavior is not seen in control animals or single lesioned animals.
Okay, and now this one is with the food item distractor, and my colleague uses Fruit Loops. Apparently rats really like Fruit Loops a lot. And what's going to happen is that the rat is going to walk across the beam, and there's the Fruit Loop is presented on the side, and it has to try and walk and retrieve the Fruit Loop at the same time. And this is a normal animal, and you can see he can get by there without difficulty. But, okay. And this is one of our pseudo-Parkinson's rats. And you can see he's a little slow to start with, and tries to get the Fruit Loop and falls, but doesn't get either one of them, as it turns out. And just so everyone knows, there's a net underneath the apparatus. So as they say in the movies, no animals were harmed in the performance of this experiment. So at that point, we're going to take a break, and I think we have another exercise video.
Today's fitness focus is going to be strength and of the arms. The props that we're going to use are dumbbells. I'm using 2-pound dumbbells. I want you to use light weights if you have them, but if you don't have them, guess what? You can use many other things in your house. A pair of cans of food, 2 water bottles that you have. Just try to make sure that they're about even weight. Let's get started with a warm-up. I'd like you to start with your arms by your side and your feet a hip distance apart. You can do this whole set in standing with me or sitting down in a chair. I'd like you to tuck your chin back and bring your gaze straight forward. Let's do that 2 more times, elongating your neck as if I'm holding a string up and pulling you. And then relax. 1 more time, give that double chin and gaze forward. Now shrug your shoulders up towards your ears and slide those shoulder blades in the pocket. 2 more times, shrugging up and lowering down. And 1 more time, shrugging up and lowering down. Now swing one arm forward as your opposite arm goes back. And now start to swing them out. Just loosening it up one side and the other for 8 more times. You might get your knees into it. You might shift side to side while you're in your chair. That's great. Give me 5 more before we grab those weights, whatever they may be. Here's your 3, Nice work. Really focus on extension as well, reaching behind you. Last time. Excellent. And stop. Now grab what you're going to use for your weights. I want you to focus on bringing your thumbs forward. We're going to warm up those shoulders by bringing your arms straight forward and down by your side. So you want to lift in what range feels comfortable to you. If you need to stop down here, that's totally fine. If you can come to shoulder height, that's great too. So you want to inhale to reach and exhale to lower for 5 more. Reach it and lower. You have 4 more. Reach and lower. Last 3. Take it up and down. Final 2. Lift, lower. Last time. Lift and lower. Now turn your palms up. Bicep curls. I want you to come all the way up and all the way down. Try to keep your elbows to your sides and focus on those Popeye muscles. You want to give them a squeeze, right? So really squeeze it and lower it. And you're halfway through this first set, so keep it going. You have 5 more. Make sure you're not locking out your knees. You want to keep a little bend to them. Last 3. Good work. Final 2. And last one. Now, self-check. Were you breathing or were you holding your breath? If you were holding your breath for the next set, I want you to count with me. Turn your palms towards you, thumbs forward. You're going to bring those thumbs up towards the shoulders and lower down. That's your 1, and here's your 2. Lower down. You've got 8 more. Here's 3. Bring it down. You've got 4. Take it down. Halfway. Keep it going. Really squeeze the bicep. Lower. You have 5 more. Final 4. Last 3. And 2. And now we get fancy. Palms go up. Alternate. Take right arm and left for 4 more sets. Here's your 3 and squeeze it. 2, keep going. Last time and stop. Thumbs face forward. Alternate again for 5 sets. Here's 4. Good. Last 3. Final 2. Last time. Relax your arms down by your sides and roll your shoulders back. We need to work your triceps. I'm going to show you my profile. I'm going to bend slightly at my hips. My elbows need to come behind my back so that I can extend the elbow and bend. Extend and bend. You can do both arms, but if this is too much, you can do a single arm. If you're sitting, you can keep this going just the same. Let's do 5 more together. Here's your 4. Good work. Last 3. Final 2. And 1. Now let's alternate. Right, left. Really squeeze and squeeze. You've got to place that focus on the squeeze. Otherwise, you can just be going through the motion. You want to really get that contraction and hold that focus. Give me 1 more time each side and stop. Stand tall. Roll your shoulders back. Now, I'm going to bend forward slightly. I'm going to reach my arms forward. I'm going to row my hands back and then bring my arms forward. Think bringing your weights to your hips and bring it forward. You can do this in standing or in sitting. The focus is on what is contracting. Really row and push. Give me 5 more here before we add on. Here's 4. Good work. Last 3. Keep it going. 2. And now we're going to add a tricep kickback. So you're going to row forward, pull to the hips, extend, and bend. Again, forward to the hips, extend, and bend. Keep going. Out, pull in, big reach, and return. You've got 5 more. Pull it in, reach it back, and return. Here's your 4. Pull it in, reach. Excellent job. 3 more. Pull it in, reach. Good. Final 2. Pull it in, reach it back, and relax. 1 more. Out, in, back, and return. Roll your shoulders back. So now we're going to work the top of the shoulder and the outside of the arm. I want you to inhale to bring your arms out to the side and exhale to lower down. If this is too much, what I would suggest doing is doing a couple of repetitions without weight. so that you can get those arms used to the resistance of gravity, which in itself is a challenge. Give me 5 more. Lower down. Here's your 4, and down. Last 3. Good work. Final 2. And last time, hold here, bend your elbows. Pull your elbows to your side, push up overhead. Pull to the side, press up. Imagine like you're making a W and push. You're halfway through, press it high, give me 5, push it up. Last 4, push it up. 3 more. Good work. Last 2. Good. Last time. Press up, lower down, roll your shoulders. An extension as well, reaching behind you. Last time, excellent, and stop. Now grab what you're going to use for your weights. I want you to focus on bringing your thumbs forward. We're gonna warm up those shoulders by bringing your arms straight forward and down by your side. So you wanna lift in what range feels comfortable to you. If you need to stop down here, that's totally fine. If you can come to shoulder height, that's great too. So you want to inhale to reach and exhale to lower for 5 more. Reach it and lower. You have 4 more. Reach and lower. Last 3. Take it up and down. Final 2. Lift, lower. Last time, lift and lower. Now turn your palms up. Bicep curls. I want you to come all the way up and all the way down. Try to keep your elbows to your sides and focus on those Popeye muscles. You want to give them a squeeze, right? So really squeeze it
Albin?
and lower it. And you're halfway through this first set, so keep it going. You have 5 more. Make sure you're not locking out your knees. You want to keep a little bend to them. Last 3. Good work. Final 2. And last one. Now, self-check. Were you breathing or were you holding your breath? If you were holding your breath for the next set, I want you to count with me. Turn your palms towards you, thumbs forward. You're gonna bring those thumbs up towards the shoulders and lower down.
Dr.
That's
Albin.
your 1, and here's your 2. Lower down, you've got 8 more. Here's 3. Bring it down.
Oh, I think
You've got 4. Take it down.
Can we pause it?
Halfway. Keep it going. Really squeeze the bicep. Lower. You have 5 more.
Yeah, we had a freezing episode, I think.
Yeah.
What do you want me to do?
I think we can keep going. I think that when the thing paused, we started it back over. So let's just get back into it, I think, if you're ready.
I'm ready. You want me to start my presentation again?
4. Last
Just
3.
I think double click to the next slide.
2.
Yeah.
And
Okay.
now we get.
Are we all set now?
Perfect. Yes. Thank you so much.
Oh, no, thank you. All right. I think we had a little freezing there. So just to resume the presentation now, talked a little bit about this already. So our colleague Martin Sartor developed an animal model of problems with gait and freezing in Parkinson's disease. And as I mentioned, he did this by essentially destroying both the dopamine system and this acetylcholine system in the brain. And the rats actually can do pretty well on most things, but as you saw in the videos, they have significant problems with walking and actually do have this freezing type behavior. Now, the background of this is that Professor Sartor has spent many years studying this acetylcholine system of the brain and has established a lot of basic knowledge about it. And in particular, a major component of this system is this thing up here, up at the top of the cartoon. And NACHR stands for nicotinic acetylcholine receptor. And this is a particular receptor for the chemical messenger acetylcholine. And this is in large part how nicotine acts in the brain. And many people who smoke will say that they smoke, it enhances their alertness, it enhances their ability to pay attention. And this is actually something you can demonstrate experimentally. And it's probably via this particular system and this particular component of this system that nicotine has its effects on attention. So this opens the possibility that you might actually be able to boost attention by manipulating this system, and in particular, focusing on this sort of nicotine aspect of the attentional system. And in particular, there's this one spot right here, a little focal part of the brain where nicotine works. And there's been a fair amount of pharmacology done on this, so some drug development in this area. And what Professor Schroeder did is he applied one of these drugs in our model of dopamine acetylcholine deficiency to see if it would reduce fall rates. And what happened is if in this animal model of Parkinson's disease plus the acetylcholine deficiency, if you give a drug that mimics some of the actions of nicotine, plus you give levodopa, you get a marked reduction in the frequency of falls of the animal. So this suggests that this kind of system actually, or activating this kind of system with a nicotine-like drug might actually be useful in reducing falls in Parkinson's disease. Now, we don't really want to use nicotine because nicotine, of course, is addictive. It actually has some other very unfavorable features. It only acts for a very short period of time, and it's strongly likely to produce significant side effects, particularly nausea. But there's been a lot of pharmaceutical industry interest in developing nicotine-like drugs, and it is possible to find another drug which has a little bit more favorable characteristics and actually use that to test the idea that we might actually be able to reduce fall frequency. But it's very difficult to do a really big clinical trial based on to reduce falls. Even though Parkinson's disease patients have a lot of falls, they still don't fall that frequently. And actually to do a proper study of any intervention for falls in Parkinson's disease actually requires hundreds of patients, and it takes probably several years to complete that kind of study. So before you actually get to a full-scale clinical trial, what you really want to do is what's called a target engagement study. And the idea of a target engagement study is you take your drug or whatever intervention you're using, and you want to see if it's actually affecting the process that you think is important in your disease. So in this particular case, if you're going to study a drug, does the drug get into the brain? And if the drug's in the brain, does it do some of the things that you think that drug is supposed to do in order to produce its beneficial effects? So what we decided to do was to try and do a target engagement study based on the idea that boosting this particular aspect of the acetylcholine system would favorably affect attention and actually gait in Parkinson's disease patients. And there's a lot of different targets that you can use, but one thing we're able to do actually is this is the acetylcholine nicotine receptor. This is the receptor that's our target for studying this particular system. And we were able to use PET imaging actually as a tool to study whether or not our drug might actually get into the brain and actually be as effective as we want. And we did this with two tools. One is the drug that we picked. This is varenicline. Now, varenicline is Chantix. This is the drug that you see advertised on television for smoking cessation. It's a nicotine-like drug. It actually has been shown in young, normal, healthy people to improve attention. And it has a lot of favorable pharmacologic characteristics. And all of you have probably seen that commercial on television, whereas that's that guy at the end talking very fast about all the side effects of varenicline. It turns out that most of those side effects are actually not side effects of varenicline. Varenicline is a very safe drug. And the second point is that we can use, as I mentioned earlier, we can use positron emission tomography to see if varenicline is actually getting in the brain and acting the way we think it should. So our first step was to take a small group of Parkinson's patients and give them, over a period of a few days, increasing amounts of varenicline, staying within the amount that's used for smoking cessation, and see whether or not varenicline actually is getting in the brain, interacting with this particular target the way we think it is. And so this is from one of our subjects. This is this individual off varenicline, and this is the individual on varenicline. You can see there's quite a dramatic difference. And this tells us, number one, the varenicline is definitely getting in the brain, and number two, that it's actually hitting specifically on the targets that we think it is. So at a dose that is actually below the dose that's usually used for smoking cessation, we can show that we actually have an effect in the system in the brain is that what we want. So the next step actually is to do a small experiment to see if we can affect other aspects of our target, which are gait function and attention. So we did what was called we did a small clinical study. This involved about 34 individuals with Parkinson's disease. And we gave them either, this is what's called a crossover design study. We either gave them varenicline or a placebo, and they were masked, and the individuals evaluating our subjects were masked for about 3 weeks. Then we take them off for a washout period. Then we cross them over to either receive varenicline or placebo. And we evaluate them at the end of each of these exposure periods just in terms of their gait and balance, and also in terms of their attention and other thinking functions. And we did a standard evaluation. Dr. Orehek mentioned the standard measures of Parkinson's disease, the UPDRS-3. We did some standard measures of thinking and memory, but also a very specific test of attentional function. And then we measured gait and balance and looking at both, particularly looking at walking speed and postural stability. And this is the ability of a person to maintain upward stance under fairly moderately demanding conditions. And this was measured with a system of sensors. So this is what's the APDA mobility system developed by a researcher in Oregon, Hoehn. And this is actually Dr. Hoehrek's mother-in-law wearing the system. And what she has sensors on the feet, on the hands, on the chest, and on the trunk. And these sensors record the individual's gait. They record pattern of movement, how stable they are when they're standing in an upright position. And from these measurements, we can extract data related to gait speed and also to a measure of postural stability. And so we did the study, we completed it last year. And to measure attention, we used this test, which is called the sustained attention test. This was, again, developed by Professor Schroeder. And this is a specific test of attention that focuses on, that is directly related to this acetylcholine system in the brain. And what you do in this task is that a signal is presented at one point, and this signal tells you whether or not you're supposed to respond when you get a second signal. And then there's a delay period, and then you get a cue to make a response. And then you have to respond either that you received that there was a signal there or there was not a signal. And there's a distractor. What happens, this is done in front of a laptop computer screen, but that laptop computer screen is flashing black and white back and forth. And I can tell you this is very difficult to do. And performance on this task is very closely related to the acetylcholine attention system. So what did we find? So we found that varenicline is very safe. We found that it was very well tolerated by our Parkinson's patients. And then when we actually looked at our data, what we'd expected that varenicline would make people walk a little bit faster. We were surprised in fact that the varenicline treated patients actually walked slower, which is not what we predicted. However, as one of my colleagues pointed out, are they walking slower because they're actually paying more attention to the surroundings about them? And we didn't see a change in their ability to control their upright posture, but we did see a change in dual task walking. So going back to the beginning of our talk, the dual task walking procedure is one in which a person's asked to walk, and then they're asked to walk with a distractor, usually counting backwards from 100 or something similar to that. And the amount of the ability of a person, or how much they slow down or change other aspects of their walking during the distractor, is a measure of their ability to pay attention. And we found that there was a significant improvement in their ability to perform this kind of dual task walking. And then on Dr. Schroeder's sustained attention task, on the varenicline, there was a significant improvement in attention. So the way we interpret this is that, number one, Varenicline gets in the brain as it should. Number two, it's definitely hitting the target that we want in terms of this specific component of the acetylcholine attention system. And number three, we do have some indications that the varenicline is doing the things that we want, that it is enhancing attention, and it is probably enhancing attention during walking in a way that's consistent with it being an effect that could be consistent with the way of being an effective agent. So with this kind of data in hand, I think what we would like to do for the future is actually to go forward and do a large study where we would actually see if varenicline actually does improve balance in Parkinson's disease, and particularly if it reduces falls. And with that, I'm happy to take any questions, and thanks very much for your time and definitely for your attention as well.
Thank you so much, Dr. Albin. We've had some questions come in. So we'll start with, what are your general recommendations for somebody who's looking to improve freezing episodes?
Right. So first of all, I have to say pretty much the same things Dr. Orehek said in her very nice talk. Freezing is tough. I think, you know, there's both freezing off treatment and there's freezing during treatment as well. Now for off treatment freezing, it's really an effort to try and to optimize your medical treatment with L-dope and other drugs. And that's where you really have to work closely with your movement disorder neurologist to try and fine tune those kind of things. For off treatment, you know, for freezing that's not responsive to L-dopa, that's very difficult. And I think I have to make the same recommendations that she made. And you have to be aware of the things that can precipitate freezing. I think gait aids can be very helpful. The type of sensitive tricks that she talked about in terms of cues and marching instead of walking. I mean, I think those are all things that can be very, very helpful. But the truth is, this is a really difficult problem, and this is why it's the topic of research. You know, and our goal would be actually to try and find better therapies to ameliorate this.
So that kind of leads perfectly into another question we've got here. Are there any non-medication interventions that we can consider when we're talking about treating balance and falls and things?
Well, I think number one, general health. I think that's important. I think, again, as Dr. Orehek said, exercise is really important. I think, you know, maintaining your fitness and you know, general exercise routines, I think that is actually something quite helpful. But it has to be done consistently, and I strongly recommend that people do it really from the outset of their illness. And again, it's exactly what Dr. Orehek said. When you need to develop a routine for these things, you need to carry it forward. What I don't think any of us can tell you is if one form of exercise is better than another. You know, intuition would say that things that concentrate on flexibility might be better, but we just don't know. I think we all have the impression that exercise is useful, but is cycling better than taking a lot of walking or running or doing another form of exercise? I think we just really don't know.
Another question here, are there any acetylcholine, nicotine, like drugs that are on the market right now that could help kind of go towards what you were discussing?
Yeah, well, varenicline is the marketed agent, and you know, varenicline is very safe. I mean, I think it got a lot of bad press actually initially, but the truth is some very, very large scale follow-up studies have shown that it's a safe agent. Now, having said that, I would not prescribe it to one of my patients because I don't prescribe anything for which I don't think there's good scientific evidence. And you know, there is a lot of, but I will say in general, there's a lot of interest in the pharmaceutical industry, not just in nicotine type drugs, but acetylcholine type drugs as well. And it may be that some of those, there may be some further developments there. Drugs that are used for dementia, like donepezil, you know, the trade name is Aricept and its cousins. There's been some interest in trying to use those drugs for gait and balance problems in Parkinson's disease. There were some promising initial findings, but I would have to say the subsequent larger studies, and I think the biggest recent study hasn't been published yet, have been negative. The problem with those drugs is they're not specific. They're really not aimed at one specific target or targets in the brain. And they may be useful for cognition in general Parkinson's patients, but probably not so much for the falls and gait problems.
We had somebody ask if you have any recommendations when it comes to foot cramping or twisting and how that plays into
Right. So that's I think that's a fairly common problem. I think that's usually an example of off-dose dystonia. Again, commonly related to the kind of motor fluctuations that you see in advancing Parkinson's disease, where people our response to medication is varying significantly over the course of the day, often predictably, but sometimes unpredictably. I think in those again, that's a situation where you really, I think, have to work with your treating neurologist to try and optimize your medical therapy. And for those individuals who are in whom you're not making progress in terms of those kind of fluctuations, and if you're otherwise eligible, deep brain stimulation can be an excellent treatment for those kind of problems.
So you were talking about, these different types of drugs, and somebody wanted to know what's the downside to simply increasing a drug like carbidopa, levodopa that you're already on. What would be the downside of simply increasing it if you're, experiencing positive results from the dose that you're on?
Well, I don't think it all depends on how well you can tolerate it and whether or not you have any other side effects. I think there's no ceiling for those kind of drugs. I mean, I think we have patients who take very high doses of these agents quite safely and without side effects, but it has to be individualized. And, are you going to have problems with your blood pressure, or some people get hallucinations at higher doses of medications? It's really very much a question of individualizing therapy. And again, this is a situation where, working with an experienced neurologist, and trying to tailor your dose to your situation, or trying to tailor your medical regimen to your situation is really the best course of action.
Okay, thank you. We have a research-related question. Wondering what your thoughts are on the research going on about spinal cord stimulation in Parkinson's disease and the improvements that they've seen in their freezing of gait.
Well, I think that's a really interesting question. There have been very variable results reported with this procedure. Certainly some individuals have reported dramatic results. I have to say I'm always a little suspicious when people report dramatic results. It's particularly with very small groups of subjects. It's really difficult to say. I think there's a real need for somebody to do a large, substantial systematic study of this procedure to see whether or not it's actually worthwhile. The animal model experiments with this procedure were actually done pretty well, and were done by very competent people. So I think it's an important line of research to pursue, but at this point I would say the clinical data is actually at best cloudy, and it really needs some more investigation.
Somebody else asked if the drug that you studied, varenicline, improves focus and cognition as well as balance.
It definitely improves attention. I think that's been shown in prior studies. It's like it's like smoking in some respects. Many people who smoke will say that taking a cigarette actually does make them feel more alert and able to focus better, and that's vindicated by decades of research. It's not going to improve all aspects of your thinking and memory, but it probably does have an impact on these. And of course, we would like to believe that it has an impact on these aspects in a way that would be helpful for Parkinson's patients, but that we have to do a lot more work on.
I think you've touched on this a little bit, but maybe just to reiterate, the drug, again, varenicline, that you were discussing, where is that in the clinical trial process? Is it like early stages, late stages?
Right. Well, it's an approved drug for the purposes of smoking cessation. The FDA approved it. It's been used by this time probably hundreds of thousands, possibly millions of people worldwide. For this particular application, it's really, I would say, nowhere. We would have to do a significant clinical trial. in order to, we would have to enter the FDA process and actually do a clinical trial to see if we get an approved indication for it. That's a big undertaking, but it's an undertaking which we're probably going to try and pursue in the next couple of years. But that's a big undertaking.
Yeah. Somebody wants to know how your research has been affected by the pandemic.
Oh, lots. So I think at my institution, and I think this is generally true, the pandemic created major problems. And of course, our primary standard is that we don't want to expose anybody to risk. So in my institution, again, I think this is typical. If you were in a therapeutic clinical trial, you continued in that trial. There were a lot of efforts made to minimize exposure to COVID. So any evaluation that could be done remotely was done remotely, and things that required in-person evaluations were done as carefully as possible. For the kind of research that we do, which is not, a lot of our research is imaging research, it's not therapeutic research, we had to stop because we didn't want elderly, particularly our older patients with Parkinson's disease, coming to our medical center where they might become infected. And we've restarted in the last few weeks, but we still have restrictions on who we're allowed to study. And I think this is generally very sensible. We're not studying any individuals who are over 65 right now, because that's a higher risk population. In fact, actually, if I was a few months older, I probably wouldn't be allowed to evaluate those patients because I would be over 65. So.
Interesting.
Yeah.
So we are on our last question, I believe, maybe our second to last. So we're wrapping up here. Do some people, this is a little out of left field, so maybe you can just touch on it with regards to what you study. Do you think that some people benefit from medical marijuana, Parkinson's patients, maybe with regards to falling, freezing, things like this?
Yeah, I have no idea, and I don't think anybody else does either. I'll say what I usually say in this. This is a fairly common question. So first of all, the way marijuana or marijuana derivatives act, there's a lot of, they do a lot of different things in the brain. And they actually are signaling with sort of marijuana-like molecules is actually an important part of basal ganglia, the part of the brain that's involved in Parkinson's disease. That it's there. I mean, it's important. What it actually does is not really known. So I would say it's completely unknown. The other comment I would make is that these are not products that are regulated by the FDA, and you really don't know who's making them, what's in them, or anything like that. So I'm actually surprised that there have been as few adverse consequences as we've seen with these kind of products in the United States. And I will also say that, like everything else, a lot of Parkinson's features are worsened by anxiety, and anxiety, as Dr. Orehek mentioned, is a very common problem in Parkinson's disease. And anything that's even a little sedating will tune down anxiety and will make people feel a little bit better, maybe make it a little bit easier for them to cope. But that's a completely non-specific effect.
Yeah. Okay. This is our last question now.
Okay.
So can you touch a little bit on the cause and treatment for Parkinson's related dementia?
Yeah. So the cause of Parkinson's related dementia is again, Dr. Orehek mentioned a little bit about this. Parkinson's is a complicated disease, and the cause of Parkinson's related dementia is probably not a single thing. So there are probably, and it varies, I think, as she mentioned, from different phases of the illness. So there are cognitive consequences to that loss of dopamine. They don't usually produce overt dementia, but it does produce some cognitive deficits. We certainly see additional cognitive problems related to this additional loss of acetylcholine that we're seeing in some patients. And that actually may have, we have some early data that may actually cause larger problems that involved in sort of more than one type of aspect of cognition. But in later disease, what appears to happen is that the pathology, the underlying pathology in Parkinson's disease, Dr. Orehek showed the BRAAK thing, the BRAAK staging system. What that shows is that the pathology starts out in a restricted number of areas of the brain, but as the disease progresses, it involves more and more of the brain. And in more advanced Parkinson's disease, many parts of the brain are involved, and consequently, there's a lot of cognitive impairment. What that means, I think, is that you probably need different treatments at different phases of the illness. And something that works, in early to moderate Parkinson's disease may not be helpful later on. And again, this is an area of active investigation, and but this I think is a particularly demanding one because we really need a treatment to address fundamental pathology in the disease, which has been very difficult.
Yeah. Great. Thank you so much for answering all those questions so thoroughly, for your amazing talk, for joining us today. We are going to move on to a really quick 5-minute break. We encourage you to join us in this video.
Hi everyone, this is Angela with the APDA, and today I'm coming to you with a few exercises to work on your balance. I know some of you have said you don't have a lot of time to do a full hour workout, so I'm going to give you 4 quick exercises, and you can do them whenever you want. You can do a couple in the morning, couple in the afternoon. You don't have to do them all 4 at the same time. It's up to you, but it'll help your balance and it'll improve your strength. So here you go. All you need, kitchen countertop. That's all you need. Or a nice sturdy chair if you're not in your kitchen. You could also do this in your bathroom at that countertop. Just something sturdy to hold on to. So the first exercise we're going to do is just knee lifts. And we're going to do a couple different variations. So the first one, you can hold on to your counter with just one arm, or if you're feeling like you need a little bit more balance, you can put 2 hands on the counter. It's up to you. I'm going to show it to you this way first and then the other way. So we're just going to lift those knees up, just one at a time, nice and slow. You don't have to lift them this high off the ground either. Even just getting your foot off the ground is good enough. Whatever you can do for that day at that time, that's all we ask. If you want to add a little bit something on, you can hold that knee up there a little bit longer. So you can hold it up there, put it back down, take the other knee, hold it up there, count to 3, put it back down. If you're feeling really balanced that day and you want to try to not hold on to the counter, just be right next to the counter so that if you do start to lose your balance, you can catch yourself. So that's the first one, super easy to do. Maybe do 10 reps, 10 on each leg, maybe do it twice a day. The second exercise we're gonna do is we're gonna walk heel to toe. So once again, you can hold on to that countertop and we're just gonna take one foot in front of the other. So if I was gonna start back here, I would just start at the end of my counter and I would just go heel in front of the other, right in front of that foot, one at a time. Once again, you feel pretty balanced. You could take your hand off the counter, but just have something to grab onto if you start to lose your balance. Really easy, but a really great one to work on balance and coordination. The next one that we're gonna do is a leg raise behind you. So we're gonna face the countertop, either in your bathroom or in your kitchen, wherever you might be, or like I said, holding on to that nice sturdy chair. But we're gonna hold on with 2 hands. We're gonna take one foot behind us, and maybe just kicking that foot back and lifting that heel off the ground in this position, maybe that's enough for you today. Totally fine. If you're feeling really good and like you really want to improve that balance, you can lift that leg off the ground. Bring it back, take the other foot back, lift it off the ground, put it down. You can do singles of those, do about maybe 5 to 10 on each leg. Once again, do it once or twice a day. That's all you need. You can also, just like the first exercise, you can hold that leg up there a little longer if you want a little bit more of a challenge. Take that foot up, hold it 1, 2, 3, set it back down. No problem. Do that, like I said, maybe once in the morning, once in the afternoon. You can do it as many times as you like. All right, the very last one that we're gonna do, I told you this would be quick and easy. We're gonna do heel raises and toe raises, all right? Once again, face that counter holding on tight. This is something that if you're feeling balanced and you can hold on with just one hand, maybe you do it while you're brushing your teeth. Maybe you do it while you're cooking something or washing some pans in the sink. But however you can do it, hold on if you need to, use your hands if you want to, but we're just gonna lift those heels up, put them back down on the ground. Lift our toes, put them back down on the ground. If both up at the same time is too much, you can also go 1 foot at a time, heel, heel, toe, toe. You don't have to do both. It's up to you depending on where you are. But I know a lot of us, since staying home, have said that balance can be a little bit more of an issue lately and that we're finding that to be a challenge. These 4 exercises, if you do them every day, will really help you improve your balance. Just a little something quick and easy. Like I said, you can multitask and do other things at the same time. Just make sure that you're safe and holding on to that nice sturdy chair or counter. I hope you guys all have a great day. Stay safe.
Welcome back, everyone. All right, welcome back, everyone. Thank you for staying with us. We are excited to ask our last polling question. Where are you viewing from today? We had many people register in Minnesota, and we even got some people from the East and West Coast. So we're just wanting to see if we have any international viewers too today. So we'll just give it a moment and wait for our results to come in. All right. Looks good. Unfortunately, no international, so we know what to do for next year. All right, I am very excited to introduce our speakers for our last presentation. Karlin Schroeder, the Director of Community Engagement at the Parkinson's Foundation, where she leads the Parkinson's advocates in research across the country. She is joined by a few of these advocates, all living in Minnesota: David Blonsky, Kim and Libby Erickson, and Liz Ogren. Welcome to all, and I'll pass it to Karlin to share her slides.
Great. Thank you so much, Erin. Really excited to be here today with the research advocates. We're going to have a chat about getting involved in Parkinson's research and how you can engage. So we're going to cover some basics about research today, and you'll hear from the research advocates about their experiences. And I'm just trying to advance our slides.
Hey, Karlin, so you'll have to share the slides from your computer. It looks like Erin's still sharing them right now.
Okay, sorry about that.
No problem.
Thank you for bearing with me. Okay, let's get this started. All right. Thank you for your patience. Just a brief introduction about the Parkinson's Foundation. The Parkinson's Foundation has 3 pillars to our work. We work to improve care for people with Parkinson's, advance research, and educate and empower the Parkinson's community. So for today, we're working hard to improve the outcomes for people with Parkinson's to have better quality of life. And one way we do that is through our Centers of Excellence Network, which are academic centers that provide multidisciplinary care. So you get care from your movement disorder specialists, but also social workers and PTs and psychologists all together working in a team for you. For tomorrow, we're working to advance research towards a better understanding of Parkinson's and ultimately, of course, a cure. We fund early investigators, people who are early in their scientific career, to encourage them to stay in Parkinson's research. And everything that we do is built on the energy and passion and experience of the global Parkinson's community. That's one of the best parts of my job, is getting to work with the people with Parkinson's and care partners who are out there fighting every day to make life better for their community. And I'm so glad you'll get to hear from some of them today. I'm just going to kick off with a quote from one of the research advocates that work with the Parkinson's Foundation. So these are folks like Kim and Libby and Dave and Liz, who you'll hear from today, and the foundation is trained in the research process. So we'll talk a bit more about that later. But Jack here, his name is actually Jackie Robinson, and he goes by Jack. He says new therapies and a cure for Parkinson's can't be found unless we feel a sense of urgency and give back to the Parkinson's community by getting involved in clinical trials. So Jack is just one of over 350 people with Parkinson's and care partners that we work with across the country to advance research. And I'd like to have our advocates who are here with us today introduce themselves. If they would just give their names, maybe say just a few words about themselves, we'll jump into our presentation. So perhaps we can start with Kim and Libby.
Are we on screen?
You are.
Okay. Kim, go ahead.
Hi, I'm Kim Erickson. I've had Parkinson's for roughly 10 years now, and shortly after being diagnosed, I decided to get involved and do something for Parkinson's research that other people weren't doing and get involved in. So I became a research advocate and have continued to participate in a bunch of different studies and so on.
And I'm Libby Erickson, his wife. My background is in nursing, and it's really helped me feel like I'm able to contribute something in nursing, in medicine, and still be taking care of my family and doing something for Parkinson's research.
Thank you. Perhaps we can go to Dave.
Good morning, good afternoon. My name is Dave Blonsky. I was diagnosed with Parkinson's in July of 2014. Before that, or actually during that time, I was actually working in the medical device industry for over 30 years, dealing with some medical devices that are typically used in a hospital setting. So I'm very familiar with the process of getting a device or a drug to market, and that was my kind of contribution. That's my contribution to the Parkinson's Foundation, is to bring the technical expertise and share that with the rest of the team across the nation.
Thanks. And Liz?
Waiting to see my picture. Do I get to see myself or no?
We see
you. You see me?
We see
you.
You
can see me. Okay, just checking. So my name is Liz Ogren. I was diagnosed in 2007, and my way of coping with Parkinson's is to be involved. My serious diagnosis is to be involved.
Check it out.
Sorry about that. Siri is talking back to me. My way of coping with the disease is by staying very physically active, and so I've been involved in helping people learn how to Nordic walk and how to bicycle on alternative wheels to keep active, and also to be involved with their Parkinson's community by being involved with the foundation or their local clinic.
Thanks. So we're going to go back to Kim and Libby and Dave and Liz to provide us some insights into this process, but I'm going to kind of set the stage for us a little bit here. So today we'll talk about types of research. I know you've been hearing about research from the other presenters today, so we'll just touch on this at a very high level. We'll talk about why you might want to consider participating in research, what you should do before deciding to participate, and where you can learn more. These slides will be provided to you, so you don't need to take notes on any of this. And if you want additional information, you can always reach out to us at the foundation. There's some important links included in these slides that we hope will help you as references. So you may have heard in the past presentation talks about different types of trials: therapeutic, interventional, observational. Research really falls into sort of two buckets of clinical studies. There's observational studies, which really look at what is happening with your Parkinson's. So you're not necessarily being given in these studies anything like a drug or exercise. It's really about watching how you live with Parkinson's and the progression of your disease. So you'll be monitored over time. This could go on for years. It can be people with Parkinson's and what we call healthy controls, people who don't have Parkinson's. And things may happen like drawing blood, asking you to complete surveys, looking for what we call biomarkers. So maybe drawing some fluid from your spine, which sounds a little scary, but if you talk to people with Parkinson's who've had it done, I've heard that it's not so bad. And we look in that fluid to see if there's markers that can tell us why you have Parkinson's, if you're at risk for Parkinson's, or how your Parkinson's might change, or maybe it's genetic testing. These studies can be really simple to participate in, and maybe not as potentially scary as some other studies might sound like to you, although we hope we can demystify some of the fears that might be around research today. So that's one bucket. Another bucket of studies is what we call interventional or therapeutic trials. And we just heard Dr. Albin talking about some of this type of research. So these are studies where something is given to you. It could be a drug, it could be a gene therapy, it could be surgery, like studies on deep brain stimulation, it could be exercise or nutritional supplements. And these are given to you to see how it might change the course of Parkinson's disease. So giving a medication to treat non-motor symptoms, or studying the effects of exercise on various motor symptoms. Those are what we call interventional trials. So I'm going to actually pause here now and just ask our panelists to go down the row and let us know if you participated in studies and what types of studies you've been in. And if you haven't participated, we can talk later about why that might be. So let's just go in order again, starting with Kim and Libby. Have you been in any studies, and what types of studies were those?
Well, I've participated in a large variety of studies, varying from filling out questionnaires to assisting researchers in developing questions for their research papers. Then I've had a bilateral DBS. I'm involved in a study with DBS modifications. Been in actual drug trials with the blind studies. So there's a tremendous variety of opportunities available. You just need to find them and take advantage of the opportunity.
Yeah, I also did the MRI studies and had the opportunity to ride in the 7 Tesla MRI at the University of Minnesota, which is an experience in itself. And I've done a few studies. I'm a little bit limited because my father also has Parkinson's, and since I'm a first-degree relative of a person with Parkinson's, it often puts me outside of that. But it's given us some great opportunities to meet the researchers and see how motivated and excited they are about their dedication to finding some answers to Parkinson's. They don't do this for the glory, they're doing it because they really care.
Dave.
Yeah, I think one of the things that my requirement was that if I wanted to be a research advocate, I had to be able to participate in some research studies. So what I've done in the last year or so is kind of join in on 4 or 5 research studies, mostly local, participating in the PD generation study at the Schroeder's Institute. There's also a gait and balance and freezing study that was part of that. And the nice part about that was they were looking for normal volunteers as well. So they took my wife, and she went through the study as well. So it's not just limited to Parkinson's patients as we go through this process. Again, just like Kim and Libby, I worked through some of the online ongoing surveys associated with Parkinson's disease, whether they come from the National Parkinson's Foundation or Michael J. Fox Foundation or whatever, just trying to get more information and a bigger picture of the things affecting PD patients.
Thanks. And Liz?
So I believe I participated in my first clinical study or something on like that sort of my first day of being diagnosed, where they took a swab of DNA because I was so interesting to them because I had family members with neurological disease. So it's kind of good to be interesting, and it's also kind of like daunting to be interesting. So I've been in the Parkinson's Outcome Project since the beginning of that. The most impactful thing that I think I've done was a drug study where I helped evaluate a drug that then later came on the market. So that was very interesting to watch that process and to learn a lot about myself physically and as I adapted to taking this trial drug that became approved. And then people mentioned the gait studies at the University of Minnesota. There's a lot of studying on people's gait and walking, which is a nice tie-in to Dr. Albin's presentation, is that there's a lot of people around the country who are studying gait, and it's interesting to see all that come together. There's so much collaboration in the community to see how much they're learning about people walking and not walking and how to make it happen. So it's a great opportunity to learn and to contribute.
So I hope what you can take away from just this brief talk here is that you have great peers in your community you can talk to who've been in research and can tell you more about their experiences. And that's something really important in helping you decide whether or not you want to take part in research if you haven't yet. So we're just going to talk a little bit about the research process here. Why are we here today talking about this? Clinical trials take a long time. So you have to do these early studies in animal models first. You have to look at different things that are happening in the lab. If you're looking at something like a drug trial, there's different phases you have to go to. You have to see if this medication is going to be safe, first of all, and you have to understand how it works in the body. And then you can finally see if it might be effective. This can take 15 years to go through this entire process of testing a new medication in humans before it can be approved and get out into the public. So it's a really long process. And we know that less than 10% of people with Parkinson's are taking part in research. So we really want to urge people today to consider taking part in studies, because only you can speed up this process through your participation, while scientists are working to speed up the process in other ways. So we really need people to take part and make it faster. Well, why would you want to take part in research? These are some things I've heard from the community. Our panelists can share more. Research might not help you in the moment today, but it might help the community and other members of the community in the future. And that's one reason why you might feel motivated to take part. We really have a great need for diverse populations to participate in research, not just people from different racial or ethnic backgrounds, but people from rural versus urban communities, people who might have lower income levels or a lower health literacy level. We need everybody to take part, because that's the only way we can understand how new therapies might work in different people, or how the disease might progress and change in different people. Right now, most people in research do tend to be white, wealthier, and oftentimes men. So we need everybody involved. We want to know what happens when something new gets out there into the public, how it's going to react in anybody's body so that we don't have any surprises. And we want to know how Parkinson's progresses across different populations so that we can help everyone. You may be getting access to an early therapy that's successful. So you may be able to get access to a drug that we eventually find out stops disease progression. And there is the opportunity to get additional medical attention. So you'll still be seeing your regular doctor, but you'll also see study doctors and other people involved in the trial, and you may learn more about your disease. We already covered this. Healthy volunteers are needed too. That contributes to our overall understanding of the disease. So I'm going to pause again, and I'm going to ask Liz and Dave, and we'll go backwards this time. We'll start with Liz. What is the main motivation for you participating in the trial, or what's one thing you'd like to share about why people take part?
I myself take part in it too, so that I can have something to do that contributes to my bettering of living with Parkinson's, of a life living with Parkinson's. So it's a way of not laying down and saying, okay, Parkinson's, you've got me. You got me cornered. I have nothing left I can do. So I participate to contribute to a cure, to sustain, to do something significant toward that, and to stay involved, just to stay involved with my community.
Dave. Hi, Dave.
Sorry about that.
There you go.
I think the interesting thing about this and why we got involved was really, I was looking at this as a big picture project for myself. I'm retired and I'm looking forward to impact something in a large way, but I'm finding more that it's more of a personal level that you have your impact at. I mean, you can have a presentation of 100 people in front of you, and maybe one will show up and stop after the presentation and talk to you about potential research studies. That's at the time when you really got to sit down and over a cup of coffee or a phone call or whatever, video conference, talk to that person about the pros and cons of research studies, answer their questions, be genuine about what to expect from a research study. It's not all the glory it sounds like. You don't get paid millions of dollars. It's important to make sure they understand that and have a realistic approach to a view of the research program.
Great. And Kim and Libby, is there anything you'd like to add?
Well, it's given us a tremendous opportunity to visit with a lot of people in support groups and at seminars. And though they resonate with the speakers about, the health experts, and that they really were drawn to talking to people with Parkinson's to see how this impacted their lives. And so we've been able to steer people through the process, get them hooked up with some of the professional researchers. That piece of it has been really nice to build that connection.
A lot of the people we've had contact with who are Parkinson's patients have stated that they could not participate in research because they didn't want to be a guinea pig. And our response to them was, if we don't participate, no one's going to do it for us. And we benefit from what we participate in. And it's important for us, it's important for our kids, it's important for our grandchildren that we participate in this and hopefully help get medical advances in drugs and hopefully finding a cure with surgeries or whatever. So it's very important that we participate and we be positive about getting the effort in, putting our effort in to getting a possible cure.
Thank you. And I really want to express on behalf of like the research community, the foundations, everybody here, how much we all as a community value the time and commitment people with Parkinson's and care partners give to take part in studies. And Kim, you're absolutely right. It wouldn't happen if the community didn't take part. And it's so incredibly valuable. So a huge thank you on behalf of all of us for all of you for taking part in this work together. I'm going to talk a little bit now about how to prepare for taking part in a study. And we'll have a few more remarks from our panelists, and then we can move on to some Q&A. So there's some important questions to ask before deciding to take part in a study. We encourage you to talk to your doctor, your movement disorder specialist or primary care physician, your family, your friends, as you're thinking about taking part. And you can ask questions like, what do I need to know about the study? Are there other treatment options I should consider? What are the risks and benefits? You'll have time to sit down with the study team and actually go through a variety of questions that you can be sure that you're fully informed before deciding whether or not you'd like to participate. Informed consent's a really key part of this process. It's not just the paper you sign, it's actually a conversation. Again, sitting down with the study team and talking about what's going to happen while you're in a study. It's meant to ensure you fully understand the research. It's not a contract. You can drop out of research at any time. If you find the study is not the right fit for you, you have concerns, other life complications come up, but we do encourage people to stay in studies as much as you can, because if you leave, we lose data, and sometimes that can lead to the study not giving us the information we hope to get from it. So there's a balance there, but certainly you should exercise your full rights. And by doing the informed consent process in depth and really having these conversations, you can know in advance what will be expected of you and help you decide in advance if maybe this isn't the right trial, rather than entering that and kind of realizing that later. But that being said, informed consent is a process throughout the whole trial. So it's not like you have this one conversation, you can never ask questions again, or you shouldn't be updated on what's happening with the study. It's a back and forth that should happen throughout the time of your participation. So we encourage you, if you're considering taking part in a study, you should be able to take that informed consent document home, talk to other people about it, or take your own time to read it and see what questions you might have. If you want to learn more about research or where you can take part in studies, we have information on our website. There's information on the NIH website. You can go to a site called clinicaltrials.gov. We know there's a lot of information there. It can be a little hard to navigate, but you can learn about trials near you or studies near you. You could go to Fox Trial Finder, which will help match you with studies that might be the best fit for you. But of course, please contact the University of Minnesota as well and ask about studies that you might be able to enter there. Kelly Brown is prepared to answer your questions. And again, you will have these slides, you'll have this contact information if you'd like to learn more. I know we touched a bit on what's happening during COVID times with Dr. Albin sharing. Studies are being run very carefully with full considerations for your health if you need to come into the clinic. So you still have the opportunity to participate in person, but there are opportunities to participate in remote trials as well. Dave mentioned one that the foundation is running, our PD generation study. This is a study that will test your genetic profile to see if you have any changes in your genes or mutations that may be related to Parkinson's. And this can help you determine what trials you might be able to be a part of and help you learn more about your Parkinson's disease overall. That's Ann Hall. She's another one of the Foundation's research advocates, and she actually helps guide PD generation from the perspective of people with Parkinson's, providing community insights so that we can be sure that the study is aligning with your needs and priorities. Another way to get involved is through our TOPAZ study. This is a study of a drug called zoldrenic acid. I should have mentioned for PD gene, you'll be sent a kit at home to do the genetic testing, and then there's some surveys for follow-up. So you don't need to go to the clinic at all. Similarly with Topaz, a nurse will come into your home and give you the zoldrenic acid through an infusion, and then you'll also have some follow-up surveys to complete. So again, you can completely do Topaz from your home. And there's also a person with Parkinson's advising this study. Her name is Lisa Hoehn. She just took over on the steering committee, although she's not pictured here. So we hope you'll consider some virtual trials that you may want to take part in too. Before I jump into the next slide, I see we're just about out of time. I just wanted to ask our panelists if they have any last thoughts they want to provide. The best part of being in a trial for you, maybe something that was a big challenge, or a word of advice you really want to leave the participants with before we go into Q&A. And let's start in the middle this time to mix it up. Dave, is there any last thoughts you want to add?
Really, I want to just emphasize the fact that it is a personal decision by people that go into a research study, and not something to be taken lightly. It may take a long time to convince them that it'll work for them, but it's worth it in the long run. I think someone mentioned that really our goal is to improve quality of life or find a cure. So without research studies, we can't do that, and we need to make sure. And we're giving every chance to the research team and every chance to the volunteers that are participating in the studies to accomplish that.
Thank you. Kim and Libby.
I've been so impressed by the quality of researchers who are guiding these studies and working them and trying to find the answer. I can't say enough about how good these people are.
Mm-hmm. Oh, well said. Yeah, thanks.
Absolutely. Liz?
I think that my advice about the research process is to remember that it's not as scary as it kind of seems on the surface, that there are lots of steps that have been taken to ensure that there is safety for the person who participates in a trial. You can always stop doing the trial on your own. Remembering again that we need research to be deep and wide, so more than 10% of the people need to be participating in research in order to speed up a breakthrough, and we just don't know when that breakthrough might come. So don't give up. Keep participating. Stay involved, and hopefully do your part to participate in something research related.
Thank you so much. I'm going to just take a few minutes on these last slides because I know we're going into Q&A. I just want to say that, if you want to be part of the program that Tim, Libby, Dave, Liz, and others are part of, this is our research advocacy program at the Parkinson's Foundation. We will train you, people with Parkinson's and care partners individually or as teams, as to how you can affect the research process. So how can you actually sit down with researchers to help prioritize research, tell researchers what's important to the community, help design studies so that we can reduce burden. So you can talk about what the outcomes of the study should be from the community perspective. How many visits and what types of tests are tolerable for people with Parkinson's? We've trained over 350 people in 42 states. These are some ways that they are improving research now that I've already touched on. So I'm not going to spend a lot of time on this slide. And I'll just close there. If you want to be a research advocate and take part in this work, please contact me. Or if you're a researcher who wants to get the perspective of people with Parkinson's and care partners into your work, please contact us also. We have tools, resources, and support to help you do that. So I'm going to stop there, and we're happy to take some Q&A.
Great, thank you, Karlin and panelists, for joining us. Got a few questions here. First, I'd like to hear what your favorite part is of participating in a research study. So, Karlin, do you want to start? Or Dave, go ahead.
Yeah, I can start with that. I think the most interesting part and the fun part for me is really talking to the research coordinator. I mean, you've got to develop a rapport, a trust with that research coordinator and understand what their study is all about. So it's really a relationship that's is key to the success of getting volunteers to join the research study. But those clinical coordinators are at each site, and they're an important key part of the process. So it's important for me and fun for me to talk to them and get to know them.
Thanks. Let's see, Liz, do you want to add anything to that? I believe you're muted.
I'm muted.
There you go.
My favorite part of being involved in research, I think, is the learning about the disease and learning about all the different things that are going on out there that give me hope.
Great. Kim and Libby, anything to add?
Well, I think the again, getting to meet the researchers and things, but you know, we go into clinics and stuff, and we're on a first name basis with physicians and other providers, and it makes it feel so intimate, in that you really have access to your caregivers in a different level. You know, and we've been doing this for 10 years now, and you know, we know people all over the Twin Cities of Minneapolis, St. Paul, and it also helps a lot if somebody asks us what we can do about getting better care for their own Parkinson's, because we know people, we can help refer them.
And I will add to that, because I am currently in an observational study. And thanks, Dave, for the shout out to the study coordinators. I love sitting down and talking to the study coordinator who patiently sits next to me as my blood is drawn, because I don't want to look at the needle and think about it. So that's wonderful to get to know her. But I think the most fun part for me is that this study provides information and updates through Twitter and social media about lessons that have been learned. And I don't know, I get a little thrill when I see that that's something that was learned, that's something new that we know, because me and other people took part in this study. It's really exciting to see that.
Great, thank you, everyone. Another question for our people with Parkinson's. What are things that you worry about most when volunteering for a study? And what are some ways that you think that could be adapted or changed to make you more comfortable?
Thanks. Liz, I'm going to call on you for that one.
Gosh, making me more comfortable, you know. I'm not that easily intimidated by the studies anymore, because I feel very comfortable with the people around town who are researching. And sorry, I'm having a roof put on my house right now, so if you hear banging, that's what that is. So making me more comfortable. I guess it's knowledge. To me, knowledge makes me more comfortable, knowing that the study has been well vetted before it comes to me, knowing that if I'm going to take a drug, that the rats have had it first, as much respect as I can have for rats, but they need to have the drug before I'm going to take it. I need to know that it's been, you know, that people have been careful. And I guess I feel like the checks and balances are in place for that to happen. Not that any system is perfect, but the thing I'd like to see most happen is that there'd be more people participating, so that it wouldn't be just that. I'd like to see that 10% go up. 10% of people participating being more people with Parkinson's participating. Yeah. That's another question.
No need to add to it, but Dave or Kim or Libby, if there's something you really want to say there, please jump in.
Yes, this is Kim. What I've been impressed with is the universities and research groups do whatever they can to make sure that you can get into a study and stay in the study so that you get good results. And they'll do as much as coming to your house to pick you up, to bring you to a research facility and bring you home at the end of the day, when you spend a long day doing testing and stuff and you're very tired. And having that ride both ways is just incredibly enabling to stay in a program and in a research program and get through it and complete it. So they do whatever they can to make you comfortable and be able to get to the sites. So it's there's a lot of help in the system to get you to these research studies.
Yeah, thanks, Kim. That's a really important point. When you're asking about taking part in a study, you can find out if there's support for your travel and transportation, or if you're traveling quite far, if there's even support for a hotel stay or for your loved one to travel with you.
All right. Another question. Many studies want someone who isn't receiving treatment yet. Are there options for those who have already started a medication?
I'm happy to take that one, and the panelists also, you can answer if you're taking a medication and we're able to still join a study. But yes, there are studies out there where you can remain on the medication that you are already on while you enter the study, or even for those studies where if you have not yet started treatment, sometimes there's an opportunity to start treatment during the course of the trial. So if you're saying, well, I'm not on medication, but I don't know if I want to start the study because then maybe I can't take medications for years, that's not necessarily true. Dave, Liz, or Kim, have you been in a study where you were able to stay on a therapy you were on and still take the new therapy or take part in the trial?
Yeah, I've been on the studies where you can stay on your therapy, but there are studies where they'd asked me to be off my therapy for 12 to 24 hours prior to doing the study. And in my case, with the rigidity factor involved with the Parkinson's, I just couldn't do that. So there's studies that I've actually declined because I did not meet their inclusion criteria, or there was something about the study that really affected me personally, that I couldn't either get there to the facility, or I could not stop taking my medication.
Yeah, thanks. And I want to reiterate here, this is what our research advocacy program is all about. It's providing this type of feedback to researchers to help make trials more accessible and more people to engage in. So sometimes we do things in a study the way we do it because we've always done it that way, and no one's really questioned it. And then we start to question it. The researchers say, you know what, we actually can change how we do that. There's also new models for studies. They've got fancy names like pragmatic trials and adaptable trials and all kinds of fancy names. But basically what it means is there may be studies where you could stay on your study drug and still get a trial drug, or maybe not get a placebo. Or, you know, again, these studies that don't involve medications, so you may be able to stay on your medications and be in an exercise trial, because there wouldn't be concern there of your medications sort of overlapping with a potential new drug. So we've been talking a lot about drug trials too, and just want to remind that there are other studies as well. Did anybody want to add anything to Dave's thoughts on that? No. Any other questions, Erin?
I have one final question. So think of me as, or think of someone you've talked with who has had Parkinson's or living with Parkinson's and is on the edge or on the fence if they should participate in a research study. What would be your top piece of advice to help them take that step towards participation?
Well, I'd love for each of our advocates to bring it home on that note. So if each of you have something to contribute, that'd be great. I see Kim and Libby look like maybe they're ready to give us a final thought.
Well, again, if we don't participate in research, it's not going to get done. So it's up to us to take care of ourselves and do whatever we can to get these research studies completed and the results out for the investigators and all for looking for cures and stuff. So it's important. We have to participate, period.
Yeah, and to let them know that the research process has always been an enjoyable one, and actually kind of sort of a fun day out on the times that we've gone. And as Kim said, they make it easy for you to get there. And it's always been a positive, always.
Dave?
I think there's a misconception that research studies are very technical, very difficult to complete. But the research studies I've been involved with are really pretty straightforward. They take a couple hours of your time, plus travel. There are usually plenty of studies around where you can get, if you're close to one facility and not close to another, you can use your closest facility studies to try to participate in that. I think it's important that people realize they're not going to fail. It's not a matter of pass or fail. It's a matter of gathering data, collecting data to make sure that we're pushing toward an endpoint that's critical in the process of either finding a better quality of life for PD patients or finding a cure.
And Liz.
I think that when we look at research, we need to remember that each one of us is a significant piece of finding that answer and finding that breakthrough that might just be around the corner. We're due for the next breakthrough in Parkinson's. There's a lot that's happened over the last 10 years, and every one of us can contribute to that happening sooner.
Thanks so much. A huge thank you to our panelists. You guys were phenomenal. Thanks so much for having this conversation with us. And thank you to the conference organizers for letting us talk about this important topic.
Thank you.
Thank you so much to our speakers and to all of you listening at home. We really can't thank you enough for joining us at our first virtual Summer Parkinson Symposium today. Another thank you to our event sponsors, AbbVie, Amneal, Acadia Pharmaceuticals, Accorda Therapeutics, Supernus Pharmaceuticals, and Medtronic. And a special thank you to our silver level sponsors, Boston Scientific and Kyowa Kirin. We will be emailing a program evaluation along shortly, and we would greatly appreciate you're taking the time to complete the evaluation, as it will help us improve our future programs. We will also be emailing a link to view presentation slides and the video of this presentation as soon as they are available. You may also contact us at any time. We're here to support you, the Parkinson's community, and we look forward to seeing you again next year. Thank you again, and we hope that you have a wonderful rest of your week.